Hello, everybody, and welcome to this conference hosted by MS Focus, the Multiple Sclerosis Foundation. I'm your host, Deborah Foreman, the Educational Programs Coordinator, and I'm joined today by Dr. Ben Thrower, who's going to answer as many of your questions as he can for the next 60 minutes. I'm delighted to introduce him. Dr. Thrower is the medical director of the Andrew C. Carlos MS Institute at the Shepherd Center in Atlanta, and he previously served as the medical director of the Holy Family MS Center in Spokane, Washington. Dr. Thrower is the senior medical advisor for the Multiple Sclerosis Foundation and enjoys contributing to their quarterly Focus magazine. Dr. Thrower, we're so pleased to have you once again, and let me give everybody some instructions as to how to answer questions or ask questions or give comments for those that haven't been with us before. So for everybody here, if you have a question or comment and you'd like to ask it, all you have to do is go to the Q&A button in the app, which also allows you to send your question anonymously if that's what you want to do. You can also ask your question live by raising your hand, and to do that, you just have to click the raise hand button or just press *9 if you're on the phone. I'll call on you, and at that time, of course, you'd have to unmute yourself to ask your question. So let's get started.
Very good. Thank you to everyone at the MS Focus. Again, I love doing these. We never know what kind of questions we're going to get, and usually there'll always be something that none of us have thought of.
Right. I agree. Okay, let's see.
While we're waiting, I would just throw out one other request. So if you come on live with one of your questions, try to keep things as kind of general as possible without getting too much into your specific medical details. We have to be a little careful that I'm not acting as your treating physician during this time. So yeah, try to keep it big picture questions.
Yeah, good point. We have an anonymous attendee who's asking, they said they've been taken off of Plegridy due to high liver enzymes and then diagnosed with grade 2 liver, which DMTs don't affect the liver enzymes. Do you have any suggestions?
So Plegridy is in our class of interferon drugs, and so all of the interferons do carry some risk of liver function issues. The one disease-modifying therapy where we would really not worry about liver issues would be glatiramer acetate, which Copaxone or Glatopa. So that class of drugs really has minimal to no risk of liver issues. I would say it's really our only disease-modifying therapy where we don't typically do labs with that drug. So that may be something to look at.
Maureen would like to know, can you talk about Ampyra? What is it? How does it work? When is it generally prescribed?
So when we talk about Ampyra, I would mention Ampyra, the generic form of it, dalfampridine, and I would also mention the kind of the grandfather of Ampyra, which is 4-aminopyridine or 4-AP. So before there was an FDA-approved Ampyra, there was 4-aminopyridine. So this is a compounded mom and pop pharmacy drug, not FDA approved. It is still out there. I would say we're probably not using it as much now because the price for generic dalfampridine has come down drastically. So these are oral medications taken twice a day. What they do is they work on potassium channels on demyelinated nerve fibers. So if you think about an area in the brain and spinal cord where the myelin's been stripped away, that area can still conduct electrical information, but it doesn't do it as well as it did when the myelin was there. And it will always be the weak link in the electrical conduction chain. So let's say you have an area of myelin damage that affects your walking. So you may start walking at a certain pace, and the further you go, the harder it is to walk. Now with a certain distance, maybe you're getting a foot drop on one side, and then you go a little further and it's foot drop on the other side. This may be even more common if it's hot outside. So that exertional or heat-related worsening of a symptom is called nerve fiber fatigue. Ampyra was really designed to work on nerve fiber fatigue. It was specifically studied to help with walking. What we know is that Ampyra, dalfampridine, 4-aminopyridine, they seem to work in about 40% of people with MS that take them. If you try one of these for about a month, you're going to know which group you're in, either the responder or the non-responder group. And we don't really understand why that is, that some people just don't respond to it. In terms of who shouldn't use those drugs, if you have any history of seizures, we need to be careful. If you have any history of kidney disease, we need to be careful because you might actually build up levels in your system because your kidney's not excreting the drug appropriately.
Karen, I'm going to go ahead and allow you to talk. So if you can unmute yourself, that would be great. Then you can ask your question.
Thank you.
Mhm.
For those of us that take Kesimpta, Ocrevus, the CD20 inhibitors, and have contracted COVID, do we have any hope of getting some natural immunity, even though we don't mount 100% response to vaccination?
Yeah, that's a great question. So we know that the B cell therapies, like you mentioned, Kesimpta, Ocrevus, any of the anti-CD20 monoclonal antibodies that are out there, they do impair the body's ability to make new antibodies. So when you think about a natural immune response or an immune response to vaccination, there's both a B and a T cell response. So we do think people on B cell therapy still make a T cell response. How effective that is in preventing another case of COVID is not entirely clear. And the problem we have with the T cell responses is really not a way of measuring it. We can measure your antibody response to either COVID or to vaccination. We just don't have a great way of measuring the T cell response. So you still do make an immune response with T cells. You don't make as much of an antibody response with B cells, but there is still something there.
Thank you.
Thank you. Thanks, Karen. Okay, so we have an email that came in, a question from Jennifer, and she said she just went off of Ocrevus because of crap gap, and then switched to Kesimpta. Any insights on efficacy of Kesimpta?
I mean, in general, we think of the B cell therapies, kind of across the board, Briumvi, Kesimpta, Rituxan, Ocrevus is probably being pretty similar. We don't have head-to-head studies, but in my experience, I think Kesimpta is just as effective as Ocrevus, Briumvi, and Rituxan. So one of the reasons we sometimes move people to Kesimpta is exactly your situation. So people are having a wearing off effect with their Ocrevus or one of the other B cell therapies, and an advantage of Kesimpta is your monthly dosing, so you have less time between doses of the medicine.
And Linda's asking, what is the best way to determine if weakness is due to progression of MS disability or due to pinched nerve?
So typically with nerve root impingement, there should be some discomfort with that. Usually, if you push on nerve root in the neck or the lower back, usually the pain, so like with the back, sciatica type pain, with the neck, pain shooting down the arm, usually the pain is a bigger issue than the weakness. That's not to say that you couldn't have some weakness from nerve root impingement, but it's just, there's usually going to be more painful. You do raise a good question that we don't want to automatically assume everything that goes on in a person with MS is their MS. We want to keep an open mind to other explanations like nerve root impingement. One of the other ways of trying to sort that out is by looking at MRI. Does your MRI show degenerative changes like bone spurs or disc bulges, disc herniations that would be significant enough to give you a nerve root impingement? And then finally, we can do a test called EMG and nerve conduction studies. This is an electrical test. If you have significant enough nerve root impingement, there should be abnormalities on the EMG test.
Teresa says, my grant ran out for my Copaxone 40 milligrams, and I went without for 3 weeks. Just restarting yesterday. Should I expect any effects, or have those little Copaxone dog guards on duty again?
So good, great question. You really shouldn't have any wearing off effect when you go off of Copaxone. So what Copaxone is doing is it's inducing a population of protective T cells in your immune system, and those T cells don't go away immediately when you stop it. They're going to linger for probably a few weeks. So it's kind of like it tapers itself slowly out of your system. When you restart it, you really shouldn't have any issues. Sometimes when people first start Glutamer or Copaxone, they do see maybe some little bit more red spots at their injection sites. Occasionally, lymph nodes getting a little bit enlarged. It's conceivable you could have a little bit of that with restarting it, but I really wouldn't anticipate that it should be anything very significant.
Thank you. Does relapsing MS progress to secondary? Does all MS progress eventually? Is it just a matter of time for progression? Do you need to have MRI changes to progress to different severity of MS?
Yeah, well, there's a lot there with that question. So the natural history of MS, if the person is not on any treatment, is that 85% of people start with relapsing remitting MS. And over time, without treatment, most people will move to secondary progressive MS. Now with treatments on board, we hope that we're drastically changing that equation. Our goal would be, by getting people on appropriate treatment as early as possible, that maybe we never move to secondary progressive MS. As people have been dealing with MS for years, there is this curious phenomenon, called progression independent of relapse activity, PIRA or PIRA. So this is the person who says, I'm getting worse, but my MRI isn't changing and I'm not having relapses. And we know this happens. It's frustrating. It's frustrating for people living with it. It's frustrating for healthcare providers. We think there's a couple of things that might be driving that. We think that loss of neural reserve, just normal human aging, and the brain and spinal cord's inability to adapt to prior injuries might drive some of that progression of disability when there's no new MRI activity. There's another concept that is sort of newer, looking at smoldering inflammation, low-level inflammation that might even be below what we can see with traditional MRI, that might be driving some of this progression when the MRI is not changing. We don't really know in a given individual who is experiencing this, how much of it is loss of neural reserve, how much of it might be that low-level inflammation. One of the things we try to do is make sure that the person is on the most appropriate therapy, being as aggressive as we can while keeping an eye on safety, and also making sure that the person is just in as good a shape as possible, that they're not deconditioned. We know that being involved in regular exercise, working with a physical therapist, working with a wellness program, these things can help push back sometimes on that progression independent of relapse activity.
Thank you. I'm taking rituximab as my DMT. Is there a test for PML or any warning signs? I know it's a rare side effect.
Yeah, I would say the best way of thinking about PML is preventing PML in the first place. The good news is that the B cell therapies carry a very, very low risk of PML. Most of the cases of PML that we have seen in people on B cell therapies are carryover cases. The person was on a prior therapy like natalizumab or Tysabri, where there is some risk of PML. If you were to stop natalizumab, your PML risk doesn't go back to low for about 6 months. So there's a window of time where maybe the person is transitioning from natalizumab over to a B cell therapy, and there have been rare cases of PML in that 6-month interval. That really isn't due to the B cell therapy. It's due to the prior therapy where there was risk of PML. So I honestly don't worry much about PML in my B cell therapy patients. We have lots of B cell therapy patients that have high JC virus antibody index values, and again, I think the risk of PML in those individuals is very, very low. Whereas we do JC virus antibody testing on an every 3-month basis in someone on natalizumab, I really don't do regular JC virus testing in my B cell therapy patients.
Interesting. Jody is asking, she said she was diagnosed in 2007 and she takes Tysabri now. Can her headaches be caused by the over 15 lesions or scars that are stable?
Pretty unlikely. So typically the lesions that we see with multiple sclerosis are not going to be a cause for headaches. There are some head pains that are directly due to MS. These are typically your neuralgias. So things like trigeminal neuralgia or extreme facial pain, occipital neuralgia, hypersensitivity on the back of the scalp where the occipital nerve sort of supplies sensation. But your more routine migraine headaches, tension type headaches, those are usually not due to the MS lesions.
Thank you. Tiffany says that her feet get really cold even while wearing slippers. Is this an MS thing?
Possibly. So a lot of people with MS do have faulty thermostats. So you can have inappropriate coldness, in a body part. The further, the nerve signal has to travel. So like with feet, the more likely it is that you might have this sensation. We certainly, again, want to be careful that we're not automatically blaming the MS. We want to make sure there's not any kind of vascular or circulatory issue. Maybe someone has diabetes or some other, condition that might put them at risk for vascular problems. Thyroid issues can sometimes cause inappropriate coldness, but if you've ruled out other medical causes, it's certainly possible that that's the MS doing that.
Okay. And Gus said, can you talk about the short and long-term side effects of, he said Mavenclad, but I think it's Mavenclad.
Mavenclad.
And are there any liver issues? Do you know what the percentage of people who are on DMTs and MS free and for how long?
So Mavenclad is one of our oral medications. It's cladribine. Cladribine is a very old medication. It's been used in certain cancers over the years. There were some IV forms that were used many years ago in other health issues. But what got FDA approval in MS is the oral form of the medication. The way that it works is sort of by resetting the immune system. So it does knock down some populations of B and T cells. And then when those cells come back, it looks like they're in a less angry state. So there's a lot less inflammation. Mavenclad really has a good safety profile. And confession here, when we were part of the original studies with cladribine, Mavenclad, I had some concerns about maybe infection risk with the drug because of its suppression of B and T cells. Infections have actually been very, very uncommon with the drug. So, as the drug has been out longer and longer, and we've collected more and more safety data, I would say we've certainly become much more comfortable with the medication. So you're going to do lab monitoring, blood counts, the B and T cell subsets to look at your immune function, and liver function studies. Liver function studies we've seen them in some patients, but it's been fairly uncommon. I would say we probably spend a little more time focusing on the immune cells than on the liver function studies. With the more efficacious drugs like Mavenclad and your B cell therapies and your natalizumab, there is a certain percentage of the population who does achieve what we call NEDA, NEDA, no evidence of disease activity. That's getting an A on your MS exam. That means you have no relapse, no progression of disability, no new MRI lesions. And a significant portion of people on these more effective therapies do really draw a line in the sand. It seems like we're stopping their MS from progressing.
Hmm. Corinne says, why does Ocrevus need to be delayed or rescheduled if you have a UTI?
So your B cell therapies are knocking down a certain population of B cells. So they are, in theory, immunocompromising you a little bit. So generally, if you have any infection, upper respiratory infection, urinary tract infection, it's probably wise to push that infusion back just a little bit until you feel better. There's not really a big risk in delaying the infusion a little bit. That effect on the B cells that we see with therapy like Ocrevus doesn't disappear quickly. It slowly kind of goes away. So sometimes it makes more sense and feels like it's safer to just push that infusion back a little bit and let you get past your active infection.
Linda, I'm not sure exactly what you're asking, but she said there would not be abnormalities on an EMG with MS disability.
So I think she's referring back to that question about separating out nerve root compression from MS. So correct. EMG is normal in the setting of multiple sclerosis. EMG is abnormal if you have a peripheral nerve issue like a nerve root impingement.
Hmm. Thank you. So Elizabeth says my Octave biomarker came back at 6 or moderate. What does that mean and what can I do about it?
So that's a great question, and I'll say I'm not sure what to do about that yet. So Octave is a company that has developed a blood test panel looking at a series of different markers for nerve fiber damage. Part of the panel is neurofilament light chain, and so these are things that might indicate that there's some level of maybe low-level inflammation under the surface. It's a really interesting test. It's completely valid. I'm not sure we know what to do with that yet. I would say if some of those markers of ongoing inflammation or damage come back elevated and you're not on therapy or you're not on a really effective therapy, maybe that's the cue to say, okay, I need to get on treatment, or maybe I need to look at being on a more effective therapy. If someone's already on a highly effective therapy, a B-cell therapy, a natalizumab, a Mavenclad, I'm not sure what we do with that information yet. I think it's interesting, but I don't know that we have an answer for that yet.
Maybe someday.
Yep.
Mary's saying, wondering if you have any opinion on the benefits of vibration plate therapy. She's previously heard about benefits associated with bone growth, but recently have heard about it helping MS.
Yep.
Just curious.
So the vibration plate is something you'll find in some health clubs. We have one here in our therapy area. So it looks like a base that you stand on, and then there's a pole that goes up, and then you have handles that you hold on to, and that base vibrates or oscillates at this incredibly high frequency. So there is data out there, as she said, showing that it may help with bone density. So maybe someone with osteoporosis might think about using one of these to try to improve bone density. There's also some literature in the MS world showing that it could improve balance. So if you have what we call a sensory ataxia, your balance is off because you can't feel position changes in your feet. We think things that improve core strength might actually help with your balance. We're not repairing the damage. We're just helping you sort of adapt to those loss of sensation. And there is data showing that the vibration plate may be one of those things that can do that. I think they're not always widely available. Again, you'll find them in some health club facilities. Some physical therapists have them. We have had individuals with MS purchase them on their own. It's about the easiest exercise you can humanly do. You just basically stand there and hold on to the handlebars, and that's it.
I like that kind of exercise.
Yes.
Mikkel wants to know if intermittent dizziness is a common symptom of primary progressive MS.
I wouldn't say it's so. Primary progressive MS, is in some ways the odd man out in the MS world, in that it's the least common cause of MS. It affects men more than women, and it really is more of a spinal cord issue than a brain issue. So most of the demyelination in primary progressive MS is going to be spinal cord directed, and that's why we tend to see more walking issues than, say, cognitive issues in primary progressive MS. Episodic dizziness wouldn't be a common thing with primary progressive MS. I wouldn't say it's impossible, but I would certainly look at other potential explanations. Could you have benign positional vertigo, which is a fairly common cause of dizziness? We have a neuro-otologist, a neurologist who specializes in dizzy here at Shepherd, and he says that one of the most under-recognized forms of vertigo he sees in just the general population is actually vertiginous migraine. So people with migraine headaches manifesting as episodic vertigo with no headache associated with it. So something to keep in mind also.
Wow, I didn't even know that existed.
Yeah, he says it's fairly common.
Wow. Okay. What are your thoughts on using a combination of metformin and alpha lipoic acid to treat PPMS?
So there's data out there, on both of these things, and I think kind of what this speaks to is the bigger picture of repurposing drugs like metformin for use in multiple sclerosis. So a lot of research on repurposing drugs that are already FDA approved for something to see if they might, have anti-inflammatory effects. Do they regenerate myelin? So there is a little bit of data for both alpha lipoic acid and for metformin. I think, when we're pushing the envelope of looking at things where it's not absolutely sure that these things work or not, I think you also have to look at the potential risks of that. Alpha lipoic acid has very little risk, and I think that's certainly fine to use. Metformin is not a risk-free drug, and so there are liver function issues that you can see with metformin. So, and then if you think about putting them together, I don't know of any study that has looked at putting them together. I get the appeal to it. If they're hitting the problem from different angles, would they work better together? Maybe. But I just don't know that we have the final data. So I would certainly run the metformin idea by your MS team so they can talk about the potential risk along with the potential benefit.
Thank you. Sarah would like to know, is there a way to tell if mood issues are due to MS or just burnout?
Yeah, I don't know that there is, because if you do depression screens and things like that, the depression we see that might be a direct result of demyelination is going to look like the depression we see maybe due to life and having stressors in life. I don't know that we can say that certain MS lesions are clearly correlated with a higher risk of mood changes like depression. So we know depression is more common in MS. We know it may be associated with the demyelination, but in a given individual, saying it's life versus MS, I don't know that we're there yet. In some ways, you could say maybe it doesn't matter too much because your treatment options probably aren't going to differ very much, whether it's directly from your MS or it's just life throwing things at you. We're going to think about things like, stress management, having you work with a counselor if appropriate, medications if appropriate. Most MS centers are going to have a certain comfort level with antidepressants. Usually we're comfortable with one antidepressant, maybe adding one on. But if the depression is refractory, it's not responding to first line medications, that's where we might bring in a psychiatrist to help us out as well.
And Teresa said, MS causes bad moods, LOL.
It can. We used to think that the
Oh,
depression that you saw in MS was just because you have a health problem and it's throwing
yeah.
weird things at you. But we know that it can be a direct result of the demyelination that we're seeing in the brain.
Is vitamin D supplement still recommended? This person saw some information about a study that showed it's not as effective as originally believed.
Yeah, the studies are mixed, and I would say that there are probably two camps in the MS world. I'm still in the believer camp. I have MS doctors that I would work with that I respect a lot who are non-believers, and you could probably find a study to support whichever position you want to take. So there have been both positive and negative trials. To me, the data showing that low vitamin D levels are associated with with higher numbers of what we call Th17 or inflammatory cells, lower T regulatory cells. I can make a better argument for correcting vitamin D deficiency than not. Obviously, we want to be judicious when we do that. Any of your fat soluble vitamins, A, D, E, and K, we don't want to mega dose blindly because there are health risks to overdoing it. So if you get too much vitamin D over long periods of time, and we would know you have too much by your blood levels, there is some risk of ectopic calcification. You start depositing calcium in places you don't want to deposit, like your kidneys. You can have a risk of kidney stones. So again, we get asked sometimes, well, what's the best dose of vitamin D? For me, the best dose of vitamin D is whatever it takes to get your blood levels up in the 50 range, in that ballpark. And for one person, that might be 2,000 units a day. For someone else, it may be 50,000 units a week. So it really is very individual.
I was told years ago by a doctor that we just never used to check for vitamin D. So nobody realized that they were below with the
Yeah.
levels, right? We may have always been below these levels.
And that yeah, and both camps have used that as an argument. Some people said, well, maybe everyone's low and it really doesn't mean anything. And other people said, no, we just underdiagnosed it. And that's why,
Yeah.
there are, so the North American Nurses trial, for instance, was this, huge study decades ago that looked at over 100,000 North American nurses for a lot of different things, heart disease and cancer risk. And they did show that in those nurses who had low vitamin D levels, there was a higher risk of autoimmune conditions later in life. Is it true and unrelated, or is it causal? And I tend to, again, I'm in the believer camp.
I know breast cancer also, they give you vitamin D supplements. They
Yep.
want you to be, on your good level. So Aram says, I just read about a study published by Pfizer in 2021 in which they'd reported using an mRNA vaccine to stop MS in mouse models. So wanted to know what you know of how that modified mRNA therapy route is progressing.
So it's still in testing. So that that was one of the positives of the whole COVID experience is we did kind of spin off this messenger RNA technology. So what they're doing with the MS vaccine with messenger RNA is they're using messenger RNA that codes for a myelin protein. So they're having cells in the human body produce a little more myelin protein in the hopes that it actually teaches your immune system to tolerate myelin protein, sort of like getting an allergy shot. So you're desensitizing yourself, say, to dog hair or ragweed. So you're basically desensitizing your immune system to myelin. So works in the animal model. We always have to be cautious. There are a lot of things that have worked in the mouse that didn't translate into humans because ultimately the mouse's immune system is not a human immune system. But fingers crossed that we see something positive out of this.
Okay, and Misty wants to know, what about magnesium as well?
So magnesium may be beneficial from a lot of different standpoints. We think about magnesium, maybe for helping prevent leg cramps. We like magnesium for migraine headache prevention. Some people think it does have positive effects in the immune system. If you tend to be a little bit on the constipated side, magnesium can have a little bit of a laxative effect. People can use magnesium either in the form of magnesium oxide or magnesium citrate. It does look like milligram for milligram that magnesium citrate gives you a little more better absorption, a little more bang for the buck. With magnesium citrate, I would with the capsules or tablets, I would probably start with somewhere in the ballpark of 250 milligrams a day. You'll know you're getting too much if your stools start getting too loose.
Hmm. I don't remember ever hearing this question, but is there an effective, it's an interesting one, an effective intervention or treatment for problematic startle reflexes?
Yeah, so not that I'm aware of. So some people with MS and some people without MS do have this really exaggerated startle reflex. I have coworkers here that I don't care how much warning you give them when you're walking up to their office. I mean, when we say hello or something, there's this very exaggerated startle reflex, and it's uncomfortable for people. Yeah, you could theorize that maybe something like a carbamazepine, an anticonvulsant that sort of tamps down some of the kind of abnormal crosstalk between nerve fibers. Theoretically, could that help? It may be a situation where the treatment might be worse than the symptom. So a lot of the things that I could think of that might help might have more side effects than is really worth it. Just interesting to think, would cannabinoids, medical cannabis, would that have a calming effect? I could theorize why it might, or even just plain old CBD, the hemp-based CBD. We know that CBD does have good anti-anxiety properties. Could it tone down? CBD is very benign. I would certainly have no problem with someone trying that out. It's widely available. Certainly an easy thing to try and see if it has an effect.
Thanks. There's somebody who says they're on trileptal,
Uh-huh.
150 milligrams 2 times a day for jaw pain. Works very well, but there are days when pain still is so noticeable that it affects their day. Is it okay to take another my Norco or ibuprofen meds do not even help relieve anything.
So that person's describing trigeminal neuralgia. So the trigeminal nerve supplies sensation here, here, and here. And the most classic form of trigeminal neuralgia is here in the jaw. So we used to use Tegretol, the cousin of Trileptal. So Tegretol is carbamazepine. That's a 3-time-a-day medicine. The advantage of the Trileptal or oxcarbazepine is that it's a twice-a-day medicine. So 150 milligrams twice a day is kind of our usual starting dose. It can go a little bit higher. So we do have people that take 300 milligrams twice a day. Run it by your MS team. So just taking an extra dose every now and then is probably not the way you want to go. This is a maintenance medicine. You want to use it to prevent the pain, not to mop up pain after you've got it. So if you're going to increase the dose, you'd want to increase it on a consistent basis, just not every now and then. So I would talk to your team about maybe bumping that dose up to 300 milligrams twice a day. We do want to do periodic blood testing. There are rare cases where white blood cells can drop with oxcarbazepine. The other thing we want to keep a watch on is your serum sodium. Occasionally it will drop with this class of drugs. And one of the effects of low sodium levels is people can just not feel well. They may be fatigued and feel like they're a little confused, which is difficult because those can be things we see with MS anyway. So again, regular blood testing is important with the oxcarbazepine.
Jake says, can you elaborate on the complications in differentiating between RRMS versus progressive and the hesitancy to officially diagnose someone with progressive MS?
So that last part, the hesitancy to use the P word, the progressive word, it's very real. We are biased against using the progressive word, and it's something that's kind of been, I think, beaten into healthcare providers over the years, because we were afraid if we put the progressive label on patients that we were taking treatment options away from them. So most disease-modifying therapies are approved for relapsing forms of MS. So if we said someone has secondary progressive MS, the fear was that we may have just taken all treatment options away from you, that your insurance company was going to look at that and say, nope, wrong label. Nothing in the MS world is black and white. So when we think about these labels, relapsing remitting MS, and then secondary progressive MS, it's not like you magically wake up one day and you jump from one box to the next. It's a spectrum, and it is not an exact science. And so because it is not a very exact science, we are sometimes we will lean more towards using that relapsing label. Things have changed a little bit now so within the past few years, we've started dividing secondary progressive MS into secondary progressive with activity and without activity. When we say with activity, we mean the person is still having relapses and or new lesions forming on MRI. I would argue that in the past, we would have used the term relapsing remitting MS for that patient. Now there's this kind of subtle differentiation between traditional relapsing remitting and a little bit more advanced into secondary progressive with activity. So that is still considered a relapsing form of MS. And even though it's secondary progressive, insurance should still cover all of your disease modifying therapies. And then there's secondary progressive MS without activity. So this means no relapses, no new lesions on MRI. And this is, I think, secondary progressive MS in the more traditional way that we think about it.
And Alyssa is asking, why are her foot spasms worse at night?
Yeah, so a lot of the uncomfortable things that MS can do will get worse at night, and it's cruel. It's unfortunate. It interrupts sleep. So both spasms and neuropathic pain, burning, hypersensitivity, frequently in the legs, will act up more at night. It may be that your conscious brain has some inhibitory influence over things like spasms and neuropathic pain, and that as we go to sleep, that kind of conscious brain becomes has less ability to inhibit those things, and that may be why we see things act up a little bit more at night. But that is a really common scenario.
This is actually interesting. Mikkel said that they found magnesium taken before bed plus sufficient hydration to basically eliminate nighttime leg spasms for her.
We do hear people say that, yeah,
Yeah.
magnesium. So spasms are, as it relates to the hydration, so spasms are notoriously stimulus responsive. If you do something that irritates your body, UTI, upper respiratory infection, stress, a pair of shoes that doesn't fit very well, you can make spasms act up. And it may be that dehydration is one of those kind of provocative factors that can kick off spasms in some people. So yeah, I'm not surprised that you can see the hydration and the magnesium help in some
Mhm.
people.
Joe Marie says that they're trying to find a way to get a good night's sleep. They were taking gabapentin, which did not work well for them mentally, but currently they're taking CBD plus THC gummies, which do help, but doesn't get them through the night. So, do you have any suggestions? Their
Yes,
feet.
I do like if you're going to use cannabinoids like CBD and THC for sleep, the gummies are better, I think, for most people than an inhaled form. If you look at inhaled THC, you get this very high, level in the central nervous system, but it comes down more quickly. So you might get to sleep, but you're not going to stay asleep, perhaps. Whereas the gummies should give you a smoother, more sustained response. Unfortunately, different people metabolize cannabinoids at different rates. So maybe that she's just a little faster metabolizer. You could
Hmm.
potentially take another dose, if you were waking up. The other thought would be, not that we want to automatically go to prescription medications, but things like trazodone. So trazodone is a very old antidepressant. Nobody uses it for depression anymore. We use it primarily as a sleep aid, and it does stick around in the system, usually a good 8 hours for people. No addictive potential with that. So you could try the trazodone if you're not able to find just the right dose on the CBD THC
Hope,
gummies.
hopefully that helps because she said that her feet are always burning and numb,
Yeah.
and she also has back pain. So,
Yeah, so the trazodone could do double duty for you.
yeah, that would be really nice. Okay, so let's see. So people with this person wants to make sure they say so people with MS do not have irregular EMG tests. That's a question.
Correct. So your EMG should not be abnormal as a result of your MS. Now, if they were to, so then the EMG is a needle, so it's electromyogram. So they're putting this very fine recording needle into a muscle. If you were having an active spasm when they're recording that, you could see muscle activity, but it's just a spasm. But no, there should not be abnormalities on EMG as a result of MS.
Okay, are there real scientific benefits of red light therapy or cold water plunges with decreasing inflammation in MS patients?
Um, Possibly. So it's interesting that they brought up the cold water plunges. We just had a research patient today that was singing the praises of cold water plunges, and this is a very reliable person. Um, there is data out there showing that you may decrease inflammatory cytokines or chemical messengers with things like cold water plunges. Um, barring some kind of cardiac issue, I don't think there's a lot of risk to doing the cold water plunges. There are facilities that people can go to where they will kind of guide you to doing this. I think there is an acclimation period. It is very, very cold water. Usually it's below 40 degrees, and they kind of gently, submerge you into that. I think they're doing about 8-minute sessions for most people. It's an area that we actually were having this discussion today with our research team that we would like to do more research on, because it looks like there could be something there, and it's certainly relatively inexpensive and easy to do. This particular patient actually bought their own plunge tank for home use, and she believes in it so strongly. She's actually been able to get off of some of her prescription medicines, her Lyrica and gabapentin have actually been discontinued, and she says her bladder function is better. So again, it's an anecdote. She's very reasonable. She said maybe it's placebo effect, but whatever it is, she feels quite a bit better.
Yeah, I got to tell you, my 34-year-old son that does not have MS does those in the morning, and it scares the heck out of me
It-
because I feel like it's has got to be shocking to your heart. So those plunges are so cold,
yeah, it
so
looks like it
cold.
would be invigorating for sure.
Whew.
Yeah.
Okay, so let's see. Can supplements omega-3, vitamin D3, milk thistle, act effective, um, etc., affect your DMT? And can you take too many of them or too many supplements?
So your vitamin D, for sure, you can take too much. Again, that's in that fat soluble vitamin. So that's one where you want to take it based upon blood levels. Milk thistle we usually think of as kind of a liver detoxicant. So really the only folks I've used that in it would be someone that maybe their liver functions are creeping up a little bit. We think it's their medicines, and we'd like to see if we can just tamp them back down a little bit. We have had some success with the milk thistle there. The omega-3s do have a little bit of an antiplatelet effect, an aspirin-like effect. So some people will bruise a little more easily with the omega-3s. I suspect if you got too much, I mean, you could have easier bleeding and bruising with those. Throw a shout out to Dr. Alan Bowling. So he has written 3 books on complementary and alternative therapies in MS. You can find them on Amazon, and those are really good consumer guides for, if you're thinking about a certain supplement, what do we know? Are there studies in multiple sclerosis? If there are not studies, what do we know in theory about how it works, and why might it be a good or a bad thing? So I would highly recommend people take a look at those.
Okay. Are there any new drugs coming down the pipeline for PPMS?
So we have this class of drugs called BTK inhibitors, Bruton tyrosine kinase inhibitors, oral therapies that work on B cells through different pathways than what we see with our current B cell therapies. Some of those are being tested in primary and secondary progressive MS. We'll see. We got some negative news a few weeks ago with one of the BTK inhibitors not meeting its endpoints in relapsing remitting MS. We don't know how that's going to affect the progressive trials, but I would say those are that's the class that would be closest to being a potential new class for primary progressive MS.
Okay, and what type of magnesium should they be taking?
So there's both magnesium oxide and magnesium citrate. I traditionally use magnesium oxide. I was talking to some of our nutritionists, and they advise that the citrate is more readily absorbed, so you get more in your system more quickly. So I think either one is fine. The magnesium citrate, because it may be absorbed a little more readily, I think might have a little more potential for loose stools. So just kind of use your judgment. If you tend to be, more on the constipated side, maybe that's a good effect from the mag citrate. Or if you already have loose stools, maybe you want to think more towards the magnesium oxide version.
Thank you. Tiffany has a question that I'm sure many people have asked themselves. Why did you choose to go into MS as a specialty?
So no family history. It was kind of a process for me. My wife's a pediatrician. When we married, she had already taken an Air Force scholarship for medical school. So we went where the Air Force told her to go for a little bit. So we finished our training in San Antonio, Texas, and the Air Force thought Spokane, Washington would be a great place for her. Spokane has a very high prevalence of multiple sclerosis. And so my practice very quickly became about 50% individuals with MS. And I just found that it was a group of individuals that I really enjoyed working with. And the other thing that for me personally as a healthcare provider, I like working with a team. I want to be surrounded by an expert in physical therapy, by someone who's a bladder specialist. And MS really does lend itself to being best managed, that comprehensive team approach. So in Spokane, what was interesting is our nearest comprehensive MS centers, you either went to Seattle or you went all the way over to see someone like Randy Shapiro in Minneapolis. So you had this huge chunk of the country where there really was no comprehensive MS care. So after spending a lot of time with people like Dr. Shapiro, with the the Jimmy Huga Center, now the Can Do MS Center. I really got a good feel for what comprehensive MS care should look like, and I really wanted that for the people in Spokane. So we presented our idea for a comprehensive MS center to the two nonprofit hospital systems, one Catholic, one Protestant. The Catholic system jumped all over it, thought it was a great fit for what their mission was, and so that's how we founded Holy Family MS Center in Spokane, and it's still there and going strong.
Nice, nice. So Teresa says, what does it mean when you're resting and out of nowhere, your arm jumps up and hits you in the head?
So that is a something called myoclonus or a myoclonic jerk. So it's kind of in the family of spasticity and spasms. So these are all things where there's increased muscle activity. And so yeah, it's just this uncontrolled muscle jerk. It can happen as you're kind of going to sleep. We see it happen when people are carrying something and all of a sudden the cup of coffee goes flying across the room. You might be able to tone those down with some of the traditional antispasmodics, things like baclofen, tizanidine, cannabinoids are all things that might decrease your likelihood of having those.
Okay. And Karen says that part two of her COVID question is, have you seen patients on B-cell depleting therapy having less severe COVID with subsequent infections?
I have not seen that. So our experience with the B-cell therapies is, people who either had COVID or who were immunized against COVID were not making a lot of antibodies. Most of our B-cell therapy patients just didn't make a good antibody response. Again, they may have had a T-cell response. When the Delta surge was hitting, I mean, that was rough on a lot of patients with B-cell therapies, and that was something that was seen globally. I think, so we had the CoV-MS registry in the United States where people were putting their data in about how people with MS were doing with COVID. And what we started seeing as the numbers came in is that our B-cell therapy patients sometimes were getting sicker, more hospitalizations, and even sometimes, unfortunately, more deaths. The good news is that as COVID is mutating, it seems to, the Omicron variants we're seeing now are certainly not Delta. I mean, knock on wood, we're not seeing high rates of hospitalizations and thank goodness deaths with the Omicron variants that are out there right now. But I don't think I've seen necessarily any kind of protective effect in our B-cell therapy patients with COVID.
Thank you. Sarah would like to know if exercise with electromuscle stimulation is beneficial.
Potentially. So there is a lot of interest in what we call FES or functional electrical stimulation. We've done research here. Dr. Deborah Backus has done studies with FES bicycles. So this is just a regular stationary bike, but the person has different muscle groups in their legs have little electrode pads on them. So when you're pedaling, if you start fatiguing, either the bike starts assisting you a little bit, or the machine, the functional electrical stimulation machine, starts stimulating the muscles for you. So one of the questions that Dr. Backus had with that research is, does that translate into better walking? So do you get better endurance by doing this type of programming? And she's published 2 studies showing that people did. So when they did this FES bike exercise program, it then equaled better endurance in the real world.
Mikkel would like to know, have you heard good or bad things about magnesium glycinate?
I have not. I know that's another form. I just have not used it. I don't think it would be inherently good or bad. Its absorption is probably closer to mag citrate. So certainly, and I don't know cost wise how it compares to the others, but I wouldn't have any concerns about someone trying it.
And Jody is saying she's sorry to ask you to repeat yourself, but what did you say about relapsing remitting as you age? Like you have stable MRIs and some symptoms, headaches, leg weaknesses, cognitive fatigue. Are these symptoms of an MS patient who is stable?
So I think one of the greatest disservices we've done to the MS community is that term relapsing remitting, because when you say remission, what a lot of people think that means is I am free of symptoms. And even in remission, people with MS are rarely free of symptoms. So when your MS is stable, you're in remission, you're still going to probably deal with something. maybe it's fatigue, maybe it's pain, maybe it's cognitive dysfunction or bladder symptoms. So those old symptoms are going to be there. And just to make life a little more interesting, those baseline symptoms when you're in remission can wobble a little bit. You can have good days and bad days. If you're dealing with fatigue, you can almost guarantee there are going to be days when your energy levels are better than others, even though you're technically stable. So, as we age, there is a tendency for our immune system to calm down a little bit. It's called immune senescence. So relapses do tend to become less frequent. New lesions on MRI become less frequent as we get older. So a little bit of calming of the immune system in a person who has a disease that's driven by a relatively overactive immune system, that calming could be a good thing. So one of the areas of a lot of research in MS is, can we potentially stop disease-modifying therapies in individuals who are stable and who are over a certain age? So there was the DISCO MS, discontinuation MS study a couple of years ago that looked at discontinuing MS therapies, more the traditional MS therapies like your glutamate, Copaxone, interferon drugs in people who were stable. And the study suggested that if you had been stable for 5 years, no new MRI lesions, no relapses, that maybe you could.
Thank you. Nicole would like to know, if a person has been stable with MRI, can old attack areas rear their head to have, say, mobility issues?
So we think that MS activity in terms of MRI, new activity could happen in one of two ways. You could form brand spanking new lesions, a new area of demyelination, or you could just enlarge an area of old demyelination. So you could, in theory, have new stuff going on in an old area. We're pretty good, in terms of looking at MRIs and saying someone has a new lesion. It's a little more difficult to sometimes detect enlarging or slowly enlarging lesions. The human eye is not as great at seeing that. We're working with a group out of Australia that has an AI, an artificial intelligence program, to look at different things on MRI. And one of the things it looks for is subtly enlarging lesions. And what this Australian group has shown is that AI is a lot better than the human eye at picking up these subtly enlarging lesions.
Okay. And Katie was kind enough to send a very lengthy question to you on through email, but I think it's too long for this. So if you wouldn't mind, I'm going to send that to you, and then we
Sure.
can get back to her with that, because there's 4 different things in the same question, and
Okay.
it's a little much. So Katie, I promise we'll get an answer to you. So Alyssa saying, what is a smoldering lesion?
Yeah, so smoldering inflammation is a relatively new concept. It's the idea that if you think of MS as a forest fire, maybe we put the forest fire out with your disease-modifying therapy, but maybe we leave behind just some kind of low-level inflammation or smoldering embers that are just under the surface, maybe subtle enough that we don't see them with traditional MRI, but they're just causing a little bit of progression of symptoms. I don't know that this science is 100% settled, but there's certainly a lot of data pointing in this direction that it may be an issue. There's a lot of research focusing on a cell in the immune system called microglial cells as maybe being one of the cells that drives this low-level inflammation. So I would say it's an interesting concept. Stay tuned to see if research kind of shows that it really is a significant issue in MS.
And Mikkel wants to know, why don't we get MRIs of more areas of the spine for PPMS?
So, I mean, we for sure want to do the cervical spine. Thoracic spine, the middle part of our spinal cord, is certainly an area where you can see demyelination. I think there's sometimes a little less excitement about the thoracic spine just because it's a harder area to look at technically. The thoracic spinal cord is skinnier than your cervical cord. It's also a little bit more prone to motion artifact. So we have individuals, for instance, that we know based upon their clinical presentation that they have demyelination in their thoracic cord, and we never see it just due to the technical limitations of the thoracic spine MRI. So it's not that we're not interested in it, it's just a more technically challenging area to look at. Sometimes we don't do MRIs as frequently in primary progressive MS just because they don't tend to change quite as much. Even when a person with primary progressive MS is changing clinically, maybe walking is getting worse, we don't always see that reflected on the MRI. I think the other thing that sometimes comes into play is, we really only have one FDA-approved therapy for primary progressive MS and Ocrevus. So let's say a person is on Ocrevus and they feel like they're getting a little bit worse. We do an MRI and maybe their cervical spine lesion has changed a little bit. Do we have anything that we can do differently? Maybe not right now because maybe the person's on the one FDA approved treatment that we have. So there are a lot of factors that go into why we may not do as many MRIs of the spine in primary progressive MS. Ultimately, though, you as the person living with MS, you have a tremendous amount of say in kind of how the course is charted. So if you're someone that says, man, I would sure sleep a lot better at night if I knew my thoracic spine MRI was unchanged, let your team know that. They may be thinking that it wouldn't change anything, but maybe for you, what it changes is it takes your anxiety levels down. So yeah, let your team know that.
Thank you, Dr. Thrower. And that wonderful answer brings us to the end of our time today. For everyone, if you've missed any part of this conference, it has been recorded and will be available through the MS Focus Facebook and YouTube channels. Reply to your registration email for information on how to access the recordings or just to sign up for our newsletter if you'd like to learn about upcoming events. Our next teleconference will be this coming Thursday, 2 days from now on January 11th, and we are going to start that again at 4:30 p.m. like this one, Eastern. Dr. Richard Burt is going to present information regarding HSCT or let me see if I do it right, hematopoietic
Good job.
stem cell transplant for MS. It is going to prove to be quite interesting for everybody, including myself and our team. Try not to miss it. I think it's going to be very informative. So as you leave this conference today, a survey will appear on your screen. We would ask that you please take just a moment to give us your feedback on the program and your suggestions for future topics. This way we can make our programming meaningful to you. Our sincere thanks to all of our attendees for your participation, and especially to Dr. Thrower, who once again astounding us with his vast knowledge and willingness to answer everyone's questions for 60 minutes. Have a wonderful evening, everyone, and we hope to see you again real soon. Thank you.
Take care, everybody.